Hello, Don here. Welcome to Podiatry Practice Mastery, where we're trying to get your practice to the $1 million mark and beyond. And we do that by, I guess, this is one thing that's really helped me. I don't know if you've tried this, but you hear this is called the $1 million minute. What this means is I'm gonna try to share what's working in my practice, what I'm doing to get to the $1 million mark. And it's right now this year I reached it at about October, the end of October. And so the 2 extra months will be kind of gravy, which is a good thing. I think $1 million mark is a good. You wonder why million, things like that. Well, I just think it's a good easy number to look at. So my basic philosophy is if you see about 20 patients a day, each patient is about $200 per visit. That'll get you about to the $1 million mark or beyond. For many people, it's beyond. And I think by kind of tracking every day, and all I do is I take my treatment, my patient schedule, and I just kind of write notes on it, and that's what I'm going through with you. So I would encourage you to do that. It just kind of keeps your eye on the prize and to figure out what's like the most valuable patient of the day. So this is going to be on a Friday. So on this Friday, I had 37 appointments. I don't usually see that many, but if you've heard this before, first half days on Fridays, I only do routine, so they're double booked. They're pretty much every 10 minutes. Those are my appointments for my Fridays. And that's the only day I do routine care is Fridays. I have a day on Friday. My other colleague does it on Thursday. Another doctor does it on Wednesday. And one of the benefits to that, I just realized we had a nail tech that was visiting us because we're trying to hire someone that can kind of work under their license as a nail tech, but we would kind of supervise them. And we're trying to work that out, and we failed twice. I just want to let you know we failed twice. The first two didn't work out. This is the third one. And what's kind of unique about this third one, I feel, is that they really appreciated the position. They appreciated kind of what we were doing. They were like respectful. They were excited about learning. So this owner of she has her own nail salon, and a little bit different than the other one that we had. I think the other one was just really busy because this one, I think she's been out a few years, and she says, guys, I'm not that busy from like in the morning until noon. So for her, this is a really good option, especially as we do our nail care and double book and only see it in the mornings, because then she can do this in the morning, and then she could see her own patients kind of in the afternoons, evenings, and weekends. So this might be a good fit for you if you're thinking about getting someone to do the nails for you. She would just come in just to do that. And she does something similar to Cariflex, and I could teach her Onifix. So I'm kind of excited about this one. We'll see how it works, and I'll let you know. But the thought would be we have 4 doctors, so she would do 4 half days, and that would be it. And we would just kind of pay her for that. So going into the day, I try to do 2 pairs of orthotics per day. So with one of the routine cares I wrote here, I did talk about orthotics. There was a patient that came in that had some issues, some maceration between the toes. So I did a antifungal between the toes, and this patient also had a kind of a rash in the front part of the leg, and I did a biopsy. So that patient, for this biopsy, I'm going to call him with the results. So once again, trying to reduce the low level visits. So these usually heal in just fine. Not going to see him back. I'm just going to kind of see what it shows. If it's an issue, then I'll have him come in. I'll have my staff contact him to come in. But just to come in to review kind of the biopsy, it's kind of a lower level visit. Also, he's having some neuropathy pain, so I'm going to check on Q10s. So that could turn into a very good patient, but that was a higher level visit because of the antifungal. Another patient that came in for routine care also had Achilles tendonitis, so they got the Achilles package like number 1, which is called the Pelto Special, which is a night splint, foam rolling, and then a morning stretch and things like that. She got an x-ray, and she'll follow up typically in 3 weeks after that. So she was here from nail care, but she also had the Achilles tendonitis. There was another patient that had some pain to the tip of the toe. We talked about possibly doing a flexor tenotomy, gave him a Crespet, so there's an office visit added to that nail care visit as well. There was another patient that came in that I was concerned, and he actually had concern of squamous cell carcinoma, and so I did refer him to dermatology. So that was kind of a level visit with my routine. Okay, so let's get big in, and then the afternoon I was seeing some other patients. I'll kind of go through what I saw. I usually do patients every 20 minutes. So the first patient was a new patient, had an IND bilaterally. Now I used to see all these INDs back. I have a page on my website. It's actually a blog page, and it has information what to look at, what they should be concerned with, and things like that. So I don't have to see these INDs back. If there's concerns, certainly they can see me. They can text a picture, but I'm trying to reduce those follow-up visits. Another patient came in for Q-Tenza. So my patients tend to come in every 3 months. I couldn't do this Q-Tenza stuff if I didn't have Diane. She is my go-to for that. She schedules it. She checks insurance and things like that. Another patient that came in for swelling and had been seen multiple times for nail fungus, had failed a couple different antifungals, and so put them on a different antifungal. What I tend to do for nail fungus, I start with Lamisil, and if that doesn't work, I'll do Diflucan. If that doesn't work, then I'll kind of switch, go down the road for those. This patient also had swelling, so I have a little list that I'm keeping in my pocket. So if I think about new things, like for example, there was this change with insurance covering now 3 pairs of compression garments per side every 6 months for lymphedema. So patients with lymphedema, I'm keeping a little record in my pocket of who has lymphedema, and I'm kind of preparing them about that, because once I get that, then I can give them a call. That's kind of the way I do it in my pocket, but you could just tell your staff if you're thinking about adding a new treatment. All I would do is I would add it to my patient presentation on swelling, and then I would reach out to patients and maybe add it to the newsletter and things like that. We're thinking about doing this now just because it can be such a kind of recurrent thing for maybe my diabetic patients. That's kind of not our focus per se, but it might be additional benefit for some of these patients. Other patient came in for plantar fasciitis. So they got my whole plantar fasciitis number 1, which is basically, I like to do meloxicam, and then my Pelto special, which is the night splint and the stretching stuff. And then I watch the patient walk, and I tend to find that on gait analysis, if I can see like the heel eversion and a mid-column collapse and stuff like that, I can talk to them about orthotics. And even if they don't do orthotics the first visit, I tend to find that they'll do it somewhere down the road. But this patient did. This patient understand the importance of kind of stabilizing everything, stabilizing the heel, and they did the orthotics. That's why they were considered the MVP. And the key really, I think, is the gait analysis. So having a structured system of watching everyone stand, watching everyone walk, makes it a little bit easier for these. As I was thinking about this, I think, like, I'm kind of, how do you say it? I have a colleague here. I do about 20, 25 pairs of orthotics a month. He does like 50. And I think really the difference, and I've asked him about this, is he's much more not comprehensive, but he talks a lot more about orthotics, and he really believes in them, and he talks a lot about not just the collapsing of the foot or the stability of the heel, but he talks about posture and the importance of stabilizing the body, and does many more. And so I'm trying to talk more, and I tend to find that the more I talk about orthotics, the more they might do it in the future. So, for example, the first visit, I'm talking about orthotics with them, and many times they'll do it, but if not, they might do it the second visit. And also the first visit, I'm talking about shockwave. So even if they're not doing it the first visit, they'll probably do it the second visit. And I think my whole video thing that I send them just kind of reinforces those things. Other patient was a Lamisil booster, which is what I do after their 3-month follow-up. That's a high-level office visit. Patient came in for an IND, and they also had a porokeratoma, so I did a lesion destruction code on that. And then there was a patient that had metatarsalgia, so first visit. So usually metatarsalgia, kind of like visit 1 is where I would do the x-rays and watch them walk and things like that, do the typical anti-inflammatories, contrast baths, and then if it's not getting better, I'll do an ultrasound at that next visit. Another patient came in for a metatarsal or orthotic modification, and I work with a company called Forward Motion. I think they're very good. I do scanning, but sometimes I need to get a replacement. That's the benefit. So they have like free replacements. They don't have to send the orthotic back. They just make a new one. And this patient, I forgot to add a metatarsal pad for them. And then another patient that came in with a cellulitis to the web space. So I gave them an antibiotic, and I'll be seeing that one. I will be seeing back. And then the last one was a patient that had kind of a bad nail that's kind of dystrophic, only grows out about a third of the way, and very thick, and patient appears to have some nail trauma. She's going to be a great candidate for Cariflex. We'll do that in the future, but not right now. So that is the day. I'd like to, just would recommend if you guys, write these down on your list of kind of what you're doing, and just find out what the most valuable patient of the day is. It just helps you kind of keep your focus and try to reduce the low value visits, increase the high level visits, and then kind of tracking things. Okay, until next time, thanks.